Hello students, today let's discuss about a very important disease which is congenital adrenal hyperplasia. Now in this congenital adrenal hyperplasia, what is the main pathology? Okay, the main hormonal abnormality in congenital adrenal hyperplasia is too much production of androgens from the adrenal cortex. So let me write it here for you. In congenital adrenal hyperplasia, the main hormonal abnormality is too much production of androgens. From where? These androgens, they are getting synthesized from the adrenal cortex. Okay, we will see why there is too much amount of androgen production. We will see in detail. But please keep this point in mind, there is too much amount of androgen production. Now, the second important point is this congenital adrenal hyperplasia, it can occur in both the sexes. Congenital adrenal hyperplasia, it can occur in females. Okay, that is in female ovaries. That it can even occur in males. Okay, so this congenital adrenal hyperplasia, this can occur in both the sexes. That's what I want to put in your mind. Now, guys, please remember, if congenital adrenal hyperplasia, if it's happening in the males, means there is there is too much amount of androgen production in the males. So will it going to be a big problem? No, usually not. Why? Because usually males have androgens. If there is too much amount of androgens in a male, that might cause the precocious puberty. So androgens in male, not a big issue. But too much amount of androgen production in females, really something bad. Okay, so what I want to keep in your mind is congenital adrenal hyperplasia, especially in females, will cause the problems. Okay, now let's see what usually happens. Usually, what is the steroidogenesis? Okay, how steroidogenesis happening in the adrenal gland? Okay, let's see that first. Now, hypothalamus. Now, hypothalamus, it will produce a hormone known as CRH, corticotropic releasing hormone. Now this corticotropic releasing hormone, it will come to the anterior pituitary. Now this anterior pituitary have different types of cells. What are the different kinds of cells which are present in the anterior pituitary? Somatotropes, thyrotropes, lactotropes, gonadotropes, corticotropes. So there are different types of cells which are present in the anterior pituitary. Now this corticotropic releasing hormone, this hormone will act on corticotropes. Okay, so these corticotropes in the anterior pituitary, they are getting acted upon by CRH. Now what happens? These corticotropes will release ACTH, adrenocorticotropic releasing hormone. Okay guys, remember this adrenocorticotropic releasing hormone, okay, adrenocorticotropic hormone, now it's going to act on adrenal gland. Here itself, let me be very clear, the main function of this ACTH is the production of cortisol. Okay, now this ACTH, it will act on adrenal gland. Now, adrenal gland will make the steroids. But please remember, when ACTH, it acts on the adrenal gland, especially adrenal cortex, whenever this adrenal gland is acted upon by ACTH, the cholesterol in the adrenal gland is going to be converted into pregnenolone. Okay, now this pregnenolone will be converted into 17-hydroxyprogesterone. Okay, okay guys, ACTH acts on the adrenal gland. In the adrenal gland, that too in the adrenal cortex, the cholesterol will be converted into pregnenolone. The pregnenolone will be converted into 17-hydroxyprogesterone. Guys, please remember, this 17-hydroxyprogesterone it can be converted into three different hormones. What are they? So this 17-hydroxyprogesterone, either it can be converted into aldosterone, okay, in the adrenal cortex. We know that aldosterone is getting from the adrenal cortex, okay, zona glomerulosa, or either it can be converted into cortisol, or either it can be converted into androgens. Okay, now please once concentrate. For the production of aldosterone, cortisol and androgens, who is giving the stimulus? It is the ACTH. Okay, adrenocorticotropic releasing hormone acts on the adrenal cortex. So in the adrenal cortex there is production of three hormones, which is aldosterone, cortisol and androgens. Now guys, I am again repeating, the main target of ACTH is, the main function of the ACTH is the production of cortisol. So mainly ACTH helps in the production of cortisol. So now guys, please remember, this cortisol, it will give negative feedback. This cortisol will give negative feedback for the production of ACTH. Okay, so cortisol is sufficient in the body, so it's giving the negative feedback for the ACTH release, so that ACTH levels will go down. Now what happens in the congenital adrenal hyperplasia? Why congenital adrenal hyperplasia is happening? Now guys, please remember, please concentrate here. This 17-hydroxyprogesterone, either it can be converted into aldosterone, either into cortisol or either into androgens. For the production of aldosterone and cortisol, guys remember, it needs an enzyme. The very important enzyme is 21-hydroxylase. Okay, so 21-hydroxylase is an important enzyme for the production of aldosterone and cortisol. Okay, 21, just write 21-hydroxylase. Now there is one more important enzyme which is also necessary for the production of aldosterone and cortisol. Now what is that? It is 11-hydroxylase. Okay, now please remember, if there is a deficiency of, okay, for example, if there is a deficiency of these enzymes, okay, there is no 21-hydroxylase or no 11-hydroxylase. If there is deficiency of these enzymes, can aldosterone be produced in adrenal cortex? No. Can cortisol be produced in adrenal cortex? No. So what happens? The 17-hydroxyprogesterone, usually it have to convert into aldosterone, cortisol and androgens. So whenever there is a deficiency of this enzyme, the 17-hydroxyprogesterone, it cannot be converted into aldosterone or cortisol. Now all the 17-hydroxyprogesterone, it will go into a pathway of androgen synthesis. So here in this person, due to the deficiency of main important enzyme which is a deficient, leading to congenital adrenal hyperplasia is 21-hydroxylase deficiency. So all the 17-hydroxyprogesterone is now diverted for the synthesis of androgens. Okay, now there is too much amount of androgens. Why? Because all the 17-hydroxyprogesterone is getting utilized for the production of androgens. Okay, so now what happens? Guys remember, these androgens, okay, in a male it will cause a precocious puberty, but in a female these too much amount of androgens will cause virilization. Okay, so this too much amount of androgens, especially in a female, will cause the virilization. What exactly is virilization? Virilization is, getting male characteristics. Okay, how? How a female is getting a male characteristics. Okay, let's see why. Guys, please remember, usually the embryological structures. Okay, let me show you. Usually these are the embryological structures: genital swellings. Okay, genital swellings, genital folds, genital tubercle. Okay, so these are the embryological structures. So don't worry. Okay, let's go one by one. Now, in a female, do you think there is androgen production during embryogenesis? Usually no. So whenever there is absence of androgens, especially dihydrotestosterone, so whenever there is no androgens in a female, what happens? These embryological structures will automatically, by default, they will convert into female external genitalia. Okay, now guys, please remember, please see, whenever there is no androgens, okay, no androgens, these structures, for example genital swellings, will be converted into labia majora. Okay, genital folds will be converted into labia minora. Genital tubercle will be converted into clitoris. Okay, please keep this point in mind. No androgens, female external genitalia. If there is androgens, what happens? The external genitalia will turn into males. For example, if there is presence of androgens or dihydrotestosterone, especially genital swellings, they will be converted into, please concentrate, scrotum. Genital folds will be converted into penile, urethra. Okay, genital tubercle will be converted into glans, penis. Okay, now these embryological structures, so the differentiation of these embryological structures either into a male external genitalia or female external genitalia depends on androgens. If there is androgens, male external genitalia; no androgens, female external genitalia. So now in our embryo, a female embryo, what's happening? Due to deficiency of 21 hydroxylase, there is too much production of androgens. Now these too much amount of androgens will convert that embryological structures into male external genitalia. So our female will have a male external genitalia or male looking genitalia. Okay, so the clitoris, what happens? That clitoris, it will enlarge and it looks like a penis. Okay, so that's what the exact problem in congenital adrenal hyperplasia. So the genitalia, okay, the two labia minora, okay, they will fuse and they will look something like a scrotum. Okay, the clitoris, it will enlarge and it will look like a penis. So by the time the girl take her birth, when you see the genitalia, how they look like? They will just look like something male. Okay, this is something look like a male genitalia. Okay, or sometimes it's not that clear. Okay, you cannot differentiate whether it's a male genitalia or female genitalia. Okay, so it causes an ambiguity. So there is development of ambiguous genitalia. Okay, so there is development of ambiguous genitalia in a congenital adrenal hyperplasia patient, especially if she is female. Now once concentrate, after that, see, our patient is genetically, okay, our patient is genetically a female. Okay, now genetically female, but when you see this phenotype of this baby, okay, phenotypically. Okay, phenotypically, she is looking something like a male. Why? Because she is having external male genitalia. So, phenotypically, she is looking like a male. So, we will call it as pseudohermaphroditism. So, genetically a female who have that phenotype of a male, this is known as pseudohermaphroditism. Especially this is an example of congenital adrenal hyperplasia is an example of female looking like a male. So, it is known as a female pseudohermaphroditism. Now, please don't forget, congenital adrenal hyperplasia is an example of female pseudohermaphroditism. Okay, so congenital adrenal hyperplasia is an example of female pseudohermaphroditism. Let's take one more example. Genetically a male, okay, genetically a male have Y chromosome. Now looking like a phenotypically looking like a female. Okay, can you guys tell me any such example? A male looking like a female means the external genitalia in this male looking like a vulva, labia majora, labia minora, clitoris, vestibule, everything is there. What is an example? Yes, if you are saying it as a testicular feminization syndrome. Okay, so testicular feminization syndrome, also known as androgen insensitivity syndrome. So this androgen insensitivity syndrome is an example of male. Let me write it for you here. So this testicular feminization syndrome is an example of male pseudohermaphroditism. Okay, so male pseudohermaphroditism. Okay guys, please keep that point in mind. Now, let's see certain other important features. What else we have to keep in mind regarding congenital adrenal hyperplasia? For example, let me see what are the clinical features, some important clinical features. Guys, remember this female, okay, this female who is actually having a male external genitalia. Okay, the genitalia is ambiguous. I am not very clear that this is whether a female looking genitalia or male looking genitalia. If I cannot have the differentiation, I am saying there is an ambiguity. Now, first of all, let me tell you, if I ask for a certain studies, okay, I just ask this person to go for the ultrasonography. Okay, now in the ultrasonography, there is presence of uterus is present. Cervix is present. Vagina, what happens? Vagina, internally, the upper two-thirds of the vagina is present. And even fallopian tubes are present. Now, all these structures are present so that I can confirm that this baby is not a male baby. Okay? So, this is a female baby having a male external genitalia. I can conclude it by doing ultrasonography. Or if I do karyotyping, okay, karyotyping, in the karyotyping, what I will see, the karyotyping is going to be 46XX. So definitely from here also I can say that this is a female baby, not a male baby, because having two X chromosomes. Now if I do bar body study, now here in this bar body study, what happens? Is there is presence of bar body or not? Yes, there is presence of a bar body. Why? Because she is a female. Now, usual females have one bar body. Okay, bar body is present. Now, let's see some other important MCQs. Okay, now clinical features. Please understand the clinical features in this patient. Guys, as there is a deficiency of 21 hydroxylase, there is no production of aldosterone or there is no production of cortisol. So, mineralocorticoid production, that is aldosterone production, and glucocorticoid production, that is cortisol production, is impaired. Guys, please remember, at least this is the basic thing you have to keep in mind. Usually, what is the function of aldosterone? Okay, please concentrate. I am showing you the kidney, last part of the nephron. Okay, last part of nephron. This is the lumen. Okay, this is lumen. This is the last part of the nephron. Okay, that is collecting tubule, distal convoluted tubule and collecting tubules. Now please concentrate. What is the function of aldosterone? Aldosterone acts on the last part of nephron. When these cells are acted upon by aldosterone, what happens? Aldosterone helps in the reabsorption of sodium, no doubt. And the same aldosterone helps in the excretion of potassium. Okay. This is what at least you have to keep in mind. So, whenever there is no aldosterone, there is no reabsorption of sodium. So, it causes what? Hyponatremia. Okay, so the patient will be having hyponatremia. So, if the patient is having less amount of sodium in his body, it causes what? Hypotension. Hypotension. Okay, so why? Because this sodium which is supposed to be absorbed, it's not getting absorbed, it's going in the urine. So along with the sodium, water will also follow, so that the patient will have hypotension. So a patient with congenital adrenal hyperplasia, especially in severe forms, salt wasting forms, there is hyponatremia and hypotension as a clinical features. Now let's see about the potassium. Usually whenever there is aldosterone, potassium should be excreted out. Now in this condition, there is no excretion of potassium. Why? Because there is no aldosterone. Whenever there is no aldosterone, potassium is retained in the body. So the retention of potassium inside the body causes hyperkalemia. Okay, so hyperkalemia is a clinical feature, especially in severe cases. So you should never forget that these clinical features, electrolyte abnormalities is seen in these patients. Now we have seen the bar body study. There is presence of the bar body. Now let's deal with the treatment part. Okay, now treatment. How we are going to treat this patient? Guys, if you want to understand the treatment, you have to know first of all why we are calling this disease as congenital adrenal hyperplasia. Okay, why there is hyperplasia of the adrenal glands? Guys, please remember, once concentrate here. Okay, in this diagram, let me show it for you in a clear way. Now okay, now please concentrate here. The prime function of ACTH is what? The prime function of adrenocorticotropic hormone ACTH is production of cortisol. But in our condition, cortisol is not getting produced. Why cortisol is not getting produced? Why? Because there is no 21 hydroxylase, main important enzyme. Okay, the main important enzyme is 21 hydroxylase. Either due to deficiency of 21 hydroxylase or 11 hydroxylase, the cortisol production is not there, aldosterone production is also not there. So whenever there is no cortisol, please remember, whenever there is no cortisol, no negative feedback. Okay, no negative feedback. So whenever there is no negative feedback, what happens? There is too much release of ACTH from the pituitary. Now this ACTH will come and stimulate the adrenal gland. It will come and stimulate the adrenal gland for the production of cortisol. But enzymes are not there, so there is no cortisol. So ACTH is continuously stimulating the adrenal glands. So there is adrenal hyperplasia. So as there is no negative feedback, there is too much amount of ACTH production. This ACTH will stimulate the adrenal gland. Okay, this ACTH will stimulate the adrenal gland. So there is hyperplasia. So hyperplasia of the adrenal gland, so that there is congenitally, by the time of birth itself, there is adrenal hyperplasia. So this ACTH is stimulating the adrenal gland to produce the cortisol. But due to the deficiency of 21 hydroxylase, cortisol is not being produced. All that 17 hydroxyprogesterone, due to the stimulation of ACTH, all the 17 hydroxyprogesterone is now utilized for the synthesis of androgens, and these androgens are causing the virilization in a female embryo. Okay, now let's see the treatment part. Guys, remember how we can treat this patient. What's the main prime pathology here? No cortisol or no steroid hormones. Okay, the glucocorticoid, which is a steroid. So as there is no steroids, there is no negative feedback on ACTH. So there is adrenal hyperplasia and there is too much androgens. So what you have to do? You have to feed this baby. You have to give this baby with steroids. You have to treat this baby with the steroids. So treatment is give steroids. Okay, so if you give the steroids, what happens? Now these steroids will go and suppress the production of ACTH, gives the negative feedback to the ACTH. So ACTH production comes down, so that there is no stimulation on the adrenal gland. If there is no stimulation on the adrenal gland, decreases the androgen synthesis from the adrenal cortex. Now, so this is the treatment. Now, what is the drug of choice for a female who is at risk of having a baby, okay, with congenital adrenal hyperplasia? So drug of choice for a female who is at a risk of having a baby with congenital adrenal hyperplasia. So what does it actually mean? Guys, remember, there is a female in her first pregnancy that there is a baby born, okay, especially a female baby born. Now this female baby is having congenital adrenal hyperplasia. Okay, mother gave birth to a child who is a female, and that baby is having congenital adrenal hyperplasia. So that if this mother conceives again, there is also a chance that the next baby can have congenital adrenal hyperplasia. So how you can prevent this? So how we are going to prevent this is by giving dexamethasone. Dexamethasone, okay, to mother. So dexamethasone, we know dexamethasone is a steroid. So dexamethasone should be given to the mother. So this dexamethasone, it will cross the placental barrier. Now this dexamethasone will go to enter into the baby circulation, and in the baby this dexamethasone will suppress the ACTH production, so that there is no androgen synthesis, so that no virilization, especially if it is a female child. Okay, so dexamethasone to the mother is given at the time of diagnosis of pregnancy. So ASAP, okay, as soon as possible after the diagnosis of pregnancy, immediately give the mother dexamethasone. Don't wait till 12 weeks, okay. So that don't think like this, okay, I will just give the steroids by doing ultrasonography at 12 weeks, so that I will know whether it's a male fetus or a female fetus. Okay, so if the male fetus, I won't give any steroids. If there is a female fetus, so that to prevent congenital adrenal hyperplasia, then I will administer the steroids. Don't do like that. Okay, so by the time of 12 weeks, there is already differentiation. Okay, the already sexual differentiation will happen by the time of 12 weeks. So even if it's a female baby, due to too much amount of androgens, what happens? There is virilization happens. So even a female baby look like a male baby. So don't delay. As soon as possible from the time of diagnosis of pregnancy, give immediately dexamethasone to the mother to prevent the congenital adrenal hyperplasia in the next baby. Okay, so a very important point. Now, what else? Don't forget that the most common enzyme deficiency, most common enzyme deficiency. The most common enzyme deficiency is what, guys? The most common enzyme deficiency is 21 hydroxylase. Okay, 21 hydroxylase is the most common enzyme that is deficient. Okay, what is the drug of choice for the mother to prevent the congenital adrenal hyperplasia? It's a dexamethasone immediately when pregnancy is diagnosed. Okay, why? Because usually sexual differentiation occurs by the end of 5th week or 6th week. Okay, so by the end of 5th week or 6th week itself, they know that external genitalia will be, differentiated. So give immediately. Okay, don't forget. So along with this, what else we can do? As there is salt wasting, okay, due to the deficiency of aldosterone, which is a mineralocorticoid, as there is the deficiency of aldosterone, there is loss of sodium from the body. So what you have to give? Give these patients, if there is salt wasting, give these patients sodium chloride. Okay, usually 4 to 6 grams. Okay, give these patients 4 to 6 grams per day. Along with this, what else we can do? Okay, do the vaginoplasty. Okay, this is a female. Okay, this is a female with the male external genitalia. Okay, so what we can do is we can take her to the plastic surgeon and we can do a vaginoplasty. Okay, recreation of the vagina. Okay, so vaginoplasty we can do in this female. Okay, so these are what are the important points we have to keep in mind while we are discussing about congenital adrenal hyperplasia. Students, also remember that in this congenital adrenal hyperplasia, as there is deficiency of 21 hydroxylase, the 17 hydroxyprogesterone, which is supposed to be converted into 3 different hormones, it's not converting into aldosterone and cortisol. So what happened, guys? The levels of 17 hydroxyprogesterone will increase. Okay, there is too much amount of ACTH production. This too much amount of ACTH, it will stimulate the adrenal cortex. Now in the adrenal cortex, the cholesterol is getting converted into too much amount of 17 hydroxyprogesterone. So what I want to put in your mind, in a patient with congenital adrenal hyperplasia, there is increased levels of 17 hydroxyprogesterone in the blood of the patient. That's usually more than 800 nanograms will be seen in the blood. Thank you.